How are you? Yeah, this is a video to show people how to do the best of both maneuver that I described in a 2005 article in the Journal of Emergency Medicine. I've sort of modified it a little bit over the years. I also would like to rename it the Taranaki Maneuver because that's where we do it now, and this is a really successful technique for reducing anterior shoulder dislocations. The reason why I really like this technique is because it combines the best of multiple techniques that are already out there, and that's why I called it the best of both maneuver. And I'm hoping that by showing people how to do it, more people will adopt this and give it a go. In my experience, about 90% of the time the shoulder is back where it needs to be within about 10 to 20 seconds. So what I recommend is that when the patient comes in, they're usually in a lot of pain. I recommend you start an IV and you can give them IV pain medicine. I recommend paracetamol, also known as acetaminophen in the US. I recommend IV nonsteroidals such as parecoxib or ketorolac, and I would recommend a dose of IV morphine such as 6 to 10 milligrams prior to the procedure. I would also recommend that you give them Entonox if you have access to this, as we do here in New Zealand. Now we're going to simulate the procedure. I'm going to ask our nurse Jasmine to pretend that she's got a dislocated shoulder. And we're going to pretend that Jasmine's right shoulder is dislocated. And so to do this procedure, we will assume that Jasmine has an IV in, and we've already given those medications, and we're going to pretend that she is sucking on the Entonox during the procedure. And we'll probably have Magesh or somebody else holding this for her so she doesn't have to do much of anything. Now, it's really important to get your hospital gurney to a 90-degree angle, or as close as possible. These gurneys, unfortunately, do not come all the way up to 90 degrees, so I usually stuff a pillow or some blankets in between the gurney and the cushion. Okay? And I would like Jasmine, the patient, to get as close as possible to here with the good shoulder. This is Jasmine's good shoulder that's not dislocated. This is the one that is dislocated. And we're going to get her leg straight up against there as much as possible and knees back. We need to move the patient back so their shoulder is right up against that, leg right up against that. And the benefit of that is we can go straight down when we push in the antecubital fossa. Now during the procedure, Magesh is going to have his hands supporting in Jasmine's axillae, okay, so that Jasmine does not flop over, okay. One of the biggest problems with this procedure is that sometimes the patients sort of flop over and move, and we want to hold them upright, okay. Now, the two doctors or trained nurses or other healthcare providers can perform the procedure as follows. One person is going to do a scapular manipulation. So I will be pushing Jasmine's right scapula medially. So I'm pushing the bottom part of the right scapula this way. I'm going to feel for the lateral aspect of the scapula, and I'm going to lean in and just push like this. I will feel with my fingers, and when I feel that scapula, I will attempt to rotate it by pushing it medially. If it's the left shoulder that's dislocated, you just reverse all of this. And yesterday, my house officer Laura did a really great job with this procedure on a patient with an acute shoulder dislocation, and we relocated that patient's shoulder in about 20 seconds. So Laura, would you hop up on the hospital gurney and show how you did that? So we're going to just show each person individually now. So go ahead and put your, so if it's Jasmine's right shoulder that's dislocated, the doctor is going to put their left hand in the patient's right antecubital fossa. And note that this arm is kept straight. And the doctor who is doing this procedure is going to put as much of his or her body weight right into that so that the arm goes down. And at the same time, you can use the other hand to rotate the arm back and forth just a little bit. Now, while Laura is doing that part, I'm doing a scapular manipulation as I showed before. And Magesh is going to support Jasmine if she starts to flop over at all by putting his hands into her axillae. Yeah, you don't have to do it right now, but that's fine. We know what it is. Occasionally, the patients who are in a lot of pain will just flip and flop over. And so we ask this supporting person to hold the patient up. Okay? But if you combine the power of the scapular manipulation and you really get a good spin, it's going to turn that glenoid fossa in such a way that it wants to accept the head of the humerus. And Laura is going to be putting her body weight right into the antecubital fossa, and by doing that at the same time, we're going to get the maximum benefit of both maneuvers. And as I said, about 90% it's going to be done in about 20, sometimes it's done in 3 seconds, sometimes 20 seconds. There's about 10% failure, and that would be primarily patients with really big, wide hips. And that's because it's really hard to go down. The other group that's pretty hard to do is very muscular, fit young men. Now, occasionally they will be able and willing to relax, but sometimes they will fight you. And that makes it harder, and some of those patients end up needing procedural sedation or need another procedure. But by and large, this procedure has been really effective and really valuable for me, and it actually saves a lot of time and gets patients out of pain faster. I've heard people talk about going slow and carefully with shoulder dislocations. I sort of tend to disagree. I actually think the faster you get the shoulder back in, the better. And I think it makes everyone happier, and it gives the patient pain relief much faster. So that's a summary of this procedure, and hopefully by doing this video I can get a lot of people to understand how to do it. Thanks.